um having problems with my video, so I apologize for not being visible
No worries.
from
No
home.
worries. No
But
worries.
I see you nice and clear. So
Okay, great.
once we get started, I will just bring the meeting to order and then um, briefly introduce you and turn it over to you. Okay?
Thank you so much. I really appreciate it.
I'll ask anyone who has questions to raise their hand chat on the chat, if that's okay, and then um, we can recognize them when you're done. Is that okay?
That sounds great. Thank you so much.
Thank you. Okay. I have 2 p.m. on my clock. I am Greg Takayama, and I apologize for not having my video working. I'm doing this from home, and for some reason my video um, feature is not working, but I can see all of you nice and clearly, and I am happy to call this Kupuna Caucus meeting to order. My name is Greg Takayama. I serve along with Representative Chun as co-chairs of the House Kupuna Caucus, and along with Senator Moriwaki, who chairs the Senate side. And together we form the Legislative Kupuna Caucus. I'm glad to step in the absence of both Representative Chun and Senator Moriwaki. Before we begin with our first speaker, I'd like to thank all of you. I have, let's see, 12 participants, a dozen, um, listed as participating, and I'd like to wish all of you, first of all, happy Grandparents' Day this Sunday. This Sunday is first Sunday after Labor Day and recognized as the National Grandparents' Day for many years. And so, to all of you who are grandparents, and I count myself as one of those lucky ones, having three grandchildren, wish you a happy um, Grandparents' Day. And as they say, do something grand. With that, I am happy to turn over presentation to today's guest, and that's Dr. Kamal Masaki, who is the chair of the geriatrics department at the John A. Burns School of Medicine. As you can see behind her, it's a beautiful school in Kaka'ako that we are blessed to have as part of our University of Hawaii campus. So with that, Dr. Masaki, let me turn it over to you and for all of the participants. If you have questions or comments, we'll ask you to raise your hand and virtually, and we'll recognize you after Dr. Masaki is done. So with that, Dr. Masaki, I turn it over to you.
Thank you so much. I really thank all of you for welcoming me into this meeting, and especially Senator Moriwaki, who was the one who asked me to come today. She asked me to give a presentation about the Department of Geriatric Medicine and what we do, to talk a little bit about the mini medical school that's hosted by JABSOM, and also to talk about the two recent legislative actions that were taken and what the progress has been towards them. So I'll start out by talking about our department. Before I do that, I just want to point out that the geriatric medicine workforce in the United States is really inadequate for our population. And I think this is particularly true in Hawaii. Everyone here knows that Hawaii is the longest lived state in the United States. Our older population is not just over 65, but we have a huge percentage of people who are over 85, even over in their 90s, and even centenarians. So the current need for the United States is estimated to be 30,000 geriatricians. The number is actually less than 7,000. And as the aging population is going up, the number of geriatricians is actually going in the opposite direction. So the gap is widening. So we're a federally designated critical shortage specialty. People often ask me, I just turned 65, should I get a geriatrician? And I always tell them, in an ideal world, yes, but in the current situation, no. We call 65 pediatrics in our field. So due to the shortage, most of the clinical geriatrics programs in Hawaii and in the rest of the country focus on consultative services or care of the very old, the very frail. We do a lot of care of patients with dementia, Alzheimer's disease, and other dementias. And we also do a lot of care in certain settings, like patients who are homebound and who need home visits, and in nursing home care, and also a lot of end of life care. And the reason we limit our services to this is really to fulfill the community needs because the needs are so high in these areas. So our department started out in 1984 as a division of geriatric medicine. This was established by my previous mentor and predecessor, Dr. Patricia Blanchette, who some of you may know. She was the first geriatrician, and I always say she's the mother and grandmother of geriatrics in Hawaii because she's the first one who came back to Hawaii and really started all the programs here. I still keep in touch with her. I still consider her my mentor, and she's wonderful. It took 20 years for us to become a full department. That was done in January 2004. At that time, we were only the fourth medical school in the United States to be granted full department status. Now, over 20 years have passed since then. And guess what? There have only been 2 additions. So even to this day, there are only 6 medical schools in the United States that have a department of geriatric medicine. In most medical schools, geriatrics is a tiny division tucked away in either internal medicine or in family medicine. Our department, we are very honored that we're a nationally designated John A. Hartford Foundation Center of Excellence in Geriatrics. We're one of 25 in the country designated as this. Our faculty is very wide. We have over 80 geriatricians and 25 other interdisciplinary faculty. As you can imagine, the care of older people really needs an interdisciplinary team. So we have representation from many other health disciplines in our faculty. I want to point out most of these faculty are actually non-compensated. They're voluntary faculty in our community healthcare systems who are volunteering their time to teach for us. And many of them are graduates of our own fellowship program and feel that loyalty towards JABSOM and towards our fellowship and other trainees. We also have a division of palliative medicine that was established in 2005, and we have over 30 faculty who have board certification in hospice and palliative medicine. So our mission and strategic goals are to achieve excellence in education, research, faculty development, clinical services, and community service. I'll give you a very brief snapshot. By the way, this is some of our folks. We're on the helipad at Kukini. Our offices are in the Kukini Nursing Home building. We're on the top floor. And this is the helipad, and that's Punchbowl in the background that you can see there. So for education, we have a very strong curriculum for JABSOM for the medical students. So this graph here represents the 4 years of medical school, first, second, third, and fourth. And when you see anything in purple, that represents either geriatrics, palliative care, or interdisciplinary team care. So you can see we're woven in very nicely throughout the curriculum. It's not just 1 or 2 or 3 experiences. It's really multiple touches that we have to the medical students. We start from the very beginning, and the reason is we're hoping that by exposing them very early, we will at least catch those few students who have the passion to take care of our elderly population. The thing that's very unusual about our curriculum is in the 4th year, there's a 4-week required rotation in geriatrics and palliative care. So this is regardless of whatever specialty the medical students are going into. They could be going into surgery or orthopedics or urology or whatever it is. They have to do 4 weeks of geriatrics and palliative medicine. And again, you'd think, given the aging population and the fact that most people, when they graduate medical school, the majority of their population will be, their patients will be elderly. Despite this, most medical schools don't have a requirement for geriatrics and palliative care. So I really have to thank our leadership at JABSOM, past and present, and hopefully future, for seeing the value of geriatrics and palliative care and giving us that support which we so badly need. In addition, we also train residents in internal medicine, family medicine, psychiatry, and others as well. We do a lot of exposure to the others. The ones we really focus our attention on, though, is internal medicine and family medicine, because many of these folks are going to become primary care doctors. And because of the shortage of geriatricians, they really need to be able to take care of older patients for the most part on their own and only refer the most complex patients to the geriatricians. We also do a lot of continuing medical education for practicing physicians and practicing health professionals. We teach allied health, so we have collaborations with all of the schools at UH and even at other universities. So the nursing, social work, public health, pharmacy, dietetics, we KCC, LCC, we do teaching for many of these programs. And JABSOM has a partnership mostly with the schools of nursing, pharmacy, social work, and public health. We've created this collaboration called the HYPE, the Hawaii Interprofessional Education Collaborative. And again, members of our department, including myself, are representatives from JABSOM to the HYPE. We also do a lot of community education on geriatric topics. And this includes the mini medical school, which I'll be talking about later in this talk. Our fellowship program is really the jewel in our crown. This is training physicians who've already finished 3 years of internal medicine or family medicine residency, and we require that they have done this in the United States. So after this, they've chosen to specialize in geriatric medicine. So they've chosen to become subspecialists. I have to give these folks a lot of credit. Geriatrics is the only subspecialty where you train more, so you have to do 1 or sometimes 2 additional years of training to actually earn less than primary care physicians. So our fellows are not doing this out of greed for sure. They're doing this because the passion that they have and the love that they have for our older population. So our fellowship program was founded in 1986. Next year, we're going to have our 40th anniversary, and we're actually planning a large celebration. We have 223 graduates to date, and of our recent graduates over the last 10 to 15 years, about half are still in Hawaii. We currently have 7 funded positions for the fellowship, so we're one of the larger programs in the country. I will tell you this, though, all over the country, fellowships are struggling to fill their positions, and we are no exception. We also struggle to fill our positions. Some years we do really well, some years not so well. So it's a constant struggle to convince people to go into this really wonderful field of geriatric medicine. Even though the pay is not high, the job satisfaction is really high. When they've done physician surveys, they've found geriatricians are the happiest doctors. So I always tell the students and residents that don't pick your specialty just based on how much you're going to earn. Our fellowship has maximum accreditation by the ACGME, which is the accrediting body. Our main training sites are Kuakini, Kaiser, Queens, the VA, and we also have some presence in some of the FQHCs, the federally qualified health centers. But really, we partner with many, many clinical and educational programs around the state. And the fellowship has been the main provider of geriatricians and leaders for the whole state of Hawaii, for JABSOM, for Queens, Kaiser, HPH, VA, and for all the hospice programs in the state as well. We have several education grants in our department. The 2 active grants that we have right now on the top of the slide, the big one is the Geriatrics Workforce Enhancement Program, also called the GWEP. This is a HRSA grant. I'll talk a little bit more about that in the next slide. One of our faculty also has an individual faculty career development award called the GACA, the Geriatrics Academic Career Award. This is also a HRSA grant. We're really proud because she was one of 26 in the country picked for this grant. So we're really proud that she was able to get it. Previous education grants that we've had include the Chief Resident Immersion Training or the CRIT program, 2 different grants from the Donald W. Reynolds Foundation, which actually has since closed. The foundation was slated to completely spend down and close their doors, and they did that several years ago. But we were lucky that we were part of the planning for 2 grants before they closed. 5 previous faculty have also had GACAs. We were a national training center for the medical student training in research, in aging research, or the MSTAR program, which is an NIH program. And of course, we've had funding from the Johnny Hartford Foundation previously, and we still continue to have the designation of Center of Excellence from them. So moving on to the GWEP then, we had a renewal in 2024. This is our third cycle, which is from the very beginning of the GWEP, we've been funded. We're very lucky because many of the other GWEP cohorts got funding for the first or the second cycle, but then they were dropped in the third cycle. So we feel very lucky that we were continued. This grant has helped us create many academic as well as community partnerships. And the overall goal is to create these age-friendly health systems using the 4Ms framework, and to try and do this throughout the state of Hawaii. And we've been very successful in doing that. So the 4Ms is, the graph is on this page. It starts with what matters to the patient. And really that's the most important M, because everything else should really gear around what's important to that particular patient. And the only way we know that is by asking and by talking to the patient. The second M is medications. I think everyone knows older people are very prone to having side effects and problems with medications. More is not always better in the elderly. In fact, often what we do in geriatrics is deprescribe, and the patients do much better. The third M is mentation, which includes things like dementia, delirium, depression. And the fourth M is mobility. Everyone, as they age, they want to remain functionally independent and be able to, take care of themselves, not have falls, things like that. So that's the fourth M. We've helped these systems get IHI certification in Hawaii. The Queen's Health System, level 2, by the way, IHI is the Institute for Healthcare Improvement, and level 2 is the highest level. So that's what we want to aim for. Queen's was the first one to achieve it with our help, with the GWEP's help. Next was the Polymomy Family Medicine Clinic. Kaiser Permanente I put in blue because we can't claim credit for helping them. Kaiser did get level 2 certification, but they did that on their own through the National Kaiser Organization, not through us. And then we've helped the VA programs and multiple FQHCs reach either level 1 or 2. And we're continuing to work with them as time goes on. CMS is now requiring that hospitals have to demonstrate that they are age-friendly in 2025. So at the end of this calendar year, all hospitals accepting Medicare patients will have to attest to the age-friendly initiatives that they have. And depending on what their score is, it will actually affect Medicare and Medicaid reimbursement 2 years down the road. So in 2027, if a hospital does poorly, their Medicare reimbursement will go down. And if they do well, their Medicare reimbursement will go up. So it really behooves our state to do well so that we get more dollars into the state. And we're working with the HAH, the Healthcare Association of Hawaii, to try and help the hospitals with this initiative as well. By the way, for this grant, so we are in the second year of a 5-year grant. Normally, it's automatic that funding will come. We don't have to compete every year. It's a 5-year grant, so we should be getting a notice of award. This year, because of all the federal changes, our notice of award came on June the 30th for a July 1st start date. So many of our staff had already received termination letters, and it was quite a mess. And then fortunately, we got it on June the 30th. So I spent that entire day reversing all those terminations and getting everybody put back on board. So I hope that Congress nationally will continue to support this program, and that we will not have this sort of tense these last minute issues every year. I hope next year will go much smoother. So another strategic goal for our department is research. We've been doing a lot with chronic disease epidemiology, and this is particularly with the Kokini Honolulu Heart Program and Honolulu Asia Aging Study of Dementia. I personally have been working with those studies for almost 35 years now. And they've provided some very valuable information about the Japanese population here in Hawaii, which can be then helping people all over the world. Our department also does nursing home research, palliative care, work in ethnogeriatrics and health literacy, quality improvement, medical education research. And we've partnered with many other health science schools and many other departments at JAPSOM as well. So I think our department, we're very proud we provide a rich academic environment for our faculty, fellows, and other trainees. For clinical services, our goal is to provide and promote excellence in clinical services for our older patients. We used to be part of USERA, which was the medical school's faculty practice plan. In September of 2021, our faculty practice merged with the Queen's group to form the Queen's University Medical Group. So now the geriatrics program, our clinical practice is part of Queen's. The Queen's Geriatrics Group has services in many settings, in the hospital setting, clinic, house calls, nursing home and assisted living, as well as palliative care and hospice. And again, our department has strong partnerships with many community organizations, even outside Queens, which include Kokini, HBH, Kaiser, VA, community clinics, many nursing homes and assisted living programs. Many of our faculty have leadership roles in nursing homes here in Hawaii. They have medical director contracts, and that really helps because not only do they provide excellent care for their own patients, but they raise the level of care for the entire community. And we also have presence in hospice programs. So I want to talk a little bit about the Dr. Rosita Leong Mini Medical School on Healthy Aging, which has been run by JAPSOM since 2014. It was actually started by the previous UH Chancellor, Dr. Virginia Hinshaw. I'm sure many of you know her. She's an amazing lady. She ran it for several years. I actually worked with her from the very beginning on it. She used to ask me for advice about speakers, and I was a speaker every year at the Mini Medical School myself. And then when she retired, she and the dean at the time asked me to take over the leadership of this. And so it's been actually my privilege to do so. It's a wonderful group of people that attend this. So the Mini Medical School is co-sponsored by the UH Cancer Center and the UH Foundation. And we provide current information about various medical topics. And I try every year to have different speakers and different topics actually look back at what we've done in previous years to make sure that we give them the most fresh information. It's usually on 5 consecutive Saturdays, and we have 2 speakers each Saturday morning, and we have 2 sessions each year. So there's a spring session, which is completely in person. The fall session is hybrid. We have an in-person, but we also have a virtual option. So this year's Mini Medical School starts on September the 27th. That's the first Saturday that we're going to have it. It's going to run from every Saturday after that, except for October the 11th. We decided this year to take a break on October the 11th because that's the day of JAPSOM's 60th anniversary celebration. So we're taking 1-day break, and then we're going to do the 3 Saturdays after that. So it goes from September the 22nd, 7th to November the 1st, with 1 break on October the 11th. The website is listed right here, and also the email address. So if you or others that you know might be interested in joining, our invitation went out a few weeks ago, so we are almost full. But fortunately, because of the virtual option, we have almost unlimited capacity to accept people. And even the in-person, I think we can squeeze in a few more if any of you would like to attend or if you'd like to recommend it to other people. Please don't hesitate to let us know if you'd like us to include somebody. These are the topics that we have for this year's Mini Medical School and the speakers. So you can see, I won't read them out, but you can see it's a very diverse group of topics. We purposely try to mix it up and have some very hardcore medical topics interspersed with some very practical things like how to use assistive devices and some other topics like, climate change and Medicare and blue zones and things like that. So try and keep it fresh and interesting every year. The spring topics are repeated in the fall. So if people have attended the spring, then you only need to attend one of the sessions because it's the same speakers and same topics for the spring and the fall session. Usually the new topics are in the spring, and then fall is a repeat of what we already did in the spring. I just have one more slide, and this is about some recent legislative actions. On the right, I have this infographic. It's actually taken straight out of the Alzheimer's Association, the national figures. You can see what the Alzheimer's and other dementias are a huge public health crisis and very costly disease, and causes a lot of pain and suffering, not only to the patient but the patient's family and caregivers. And I personally have had experience with this, with family members who had dementia, and I can tell you it is a very, very difficult thing, not only for the patient, but also for the family to live with. So we're very grateful for these two bills. One bill and one resolution. So Senate Bill 1252 passed, and essentially it's to coordinate curriculum and training in dementia for all the healthcare schools and providers. And it gives us two faculty positions in geriatrics for 2 years. And we will be providing annual progress reports to the legislator as well. I just wrote the job descriptions last weekend, and I'm waiting for HR and the dean's office and others to send me back comments. And we're hoping actually that we can advertise those two positions very soon. The other one is Senate Resolution 163, which is to explore the feasibility of establishing an Alzheimer's disease research center with NIA funding in the state of Hawaii at JAPSOM. And that one is a little bit more tricky. Yesterday, I actually attended an 2/3 of the day session, which was hosted by the Department of Health about dementia and about the state plan in dementia. So many of the state's dementia experts and educators and other people in public health were all there. So it was nice. And we actually talked about this resolution a little bit. And we did come up with some action plans that we will put forward. It is the first step we're going to do is look and see what's currently being done in dementia research in the state of Hawaii. And I have a list of people I'm going to be sending out emails to this weekend to kind of give me something that I can put together so that we have a very comprehensive list of what's happening already. Then this group is supposed to talk about the potential benefits of having an ADRC in Hawaii and provide a phased plan and timeline and kind of go over the funding requirements. And there's a report due to the legislature in December of 2025. I can tell you, I did look up the requirements of an ADRC, and it is a lot. So I don't think, I know we don't have the bandwidth right now, but with the other experts, I am going to be taking a look at what we might need in order to put together a plan for a possible ADRC in the future. And that's all I have. So I'm going to stop my share and see if anyone has any questions. Thank you all so much for listening.
Thank you so much, Dr. Masaki. That was very informative. Um, I'd like to thank, I noticed we have about a dozen other participants who signed on after you began talking. Just to explain, I'm Greg Takayama. I'm hosting, but my video is not working, so I apologize for that. But I can see all of you who have video on. Um, if you have any, excuse me, questions, please use the chat box or raise your hand virtually under chat. I'd like to begin, if I could, Dr. Masaki, by asking, you might want to explain what an ADRC is for those who may not be
Yeah.
familiar with it.
Yes. So ADRC stands for Alzheimer's Disease Research Center. And I
Mhm.
looked it up just this past week. There are 30 something centers in the United States. They're all at very major research intensive medical schools around the country. It takes a lot to apply, even to apply for an ADRC grant. And of course, they're very competitive. So you need to have not just one or two or even three research programs. There's some requirements that you need to have a certain core group of researchers that do research in Alzheimer's, a clinical core, an education core, a pathology core, so that you can do autopsies and brain work and all of that. So it is a lot that's required. I don't think the state of Hawaii can do it right now, honestly,
Okay.
but we could work towards it. And so that's going to be our task. The people we talked to yesterday, that was what we discussed, is maybe we should talk about a phased approach, about all of the things that we would need to get and build in order to be even competitive to apply for a grant. Right now, it wouldn't even be feasible to apply for an ADRC. We don't have the pieces in place. But down the
Thank you.
road, it could be a possibility.
Okay. I also wanted to mention, in addition to the legislative measures you mentioned, there was another one that related to Alzheimer's, and that's one that requires Medicare recipients as part of their annual physical exam, that it incorporate a screening for Alzheimer's um, disease as well. So that was also enacted.
We're super happy about that because I think early detection is the key for dementia. And the primary care physicians, unfortunately, have not been very good about it. Part of it, I think, is just time. They're so busy. Part of it is maybe lack of knowledge. So I think having this requirement is very important. We want to
Good,
pick up
good.
cases very early if possible.
Thank you. Any participants have any questions? Dr.
Audrey,
Lewin, go ahead. I see you there. Please proceed.
Yes, thank you. Kamal, you're such an icon and so fantastic. You were doing all this when I was director of health, just with Pat and the rest. So thank you for the leadership that you've exhibited for all these years. It really, really pays off for our state. I wanted to ask you to maybe help us with thinking about what we need to do next and now for our kupuna in terms of some of the priorities that are out there. I want to recall, just as an aside, that during the legislature this year, I know that Chair Takayama and Senator some of the rest, Senator Moriwaki and others that are on this call, recall that we had a data request for Alzheimer's disease in the legislature. I think I've been able to get the relationship set up between the Health Information Exchange in Hawaii and the Alzheimer's Association, so we can start gathering data on people at risk for, early stages of, and people suffering with Alzheimer's, and so that we have better data and understanding. So we're doing that. But we'd love to hear about what other kinds of issues outside of this amazing work that you'd like to see us focus on for Kupuna.
yeah, thank you. Thank you so much. So I think that the what you guys have already given us, that Senate bill that got passed that gave us the two positions to basically look at the curriculum and all the health health profession schools and to collaborate with the schools and to kind of make sure that the dementia teaching is good, not just in the medical school, but in these other schools, right? It's not just doctors who work with dementia patients. It's the nurses, the social workers, the pharmacists, and others. So I think that's it. I'm really grateful for those two positions because I think that will do a lot in kind of bringing all these educational programs together and doing some looking at the community education programs too, because it's important to educate everyone in the community, the families, because they're the ones who sometimes recognize this first. Yesterday, the Alzheimer's Association talked about this dementia friendly program where, the patients with dementia are going to be out there. They go to the store, they go to the bank. Some of them are unrecognized. So it's very important for us to train the community to be recognizing these issues and to have a suspicion like, hey, I wonder if I should let somebody know. Because we know that some of these patients can actually be really taken advantage of financially and in other ways.
Mm.
So to put in a lot of safeguards for early recognition and education of the whole community, I think is really critical. I see many other experts in dementia care on this call. So please, all of you, please feel free to unmute and speak up. Audrey put a comment in the chat that ADRC also stands for Aging and Disability Resource Center in Hawaii. I know it does cause confusion, doesn't it? See, to me, because I'm in dementia, that's my field. ADRC is always Alzheimer's Disease Research Center, but other people see ADRC as something different. So I agree it's a problem, but I don't know if it's going to change because the ADRC program on the NIH level has existed for many years now.
Mm. Okay, thank you very much. Anybody else with questions? In the meantime, Doctor, I have a question. How many JAPSOM students are enrolled in the geriatrics program currently?
Okay, so in the fellowship currently? In the
Yeah,
fellowship, yeah.
yeah,
So the
or in the
JAPS,
curriculum. Yes,
okay, so
go
JAPSOM,
ahead.
the curriculum has the JAPSOM class size is 77, and all 77 get geriatrics, some geriatrics training throughout their medical school career. So we're doing all of them, so 77 multiplied
Okay.
by
Oh,
4.
I see. Okay.
Plus, we do internal medicine and family medicine residents and psychiatry residents. So I think in the last count, we're doing about, for clinical rotations, we have about 100 and, yeah, it's for the residents, it's about maybe 35 to 40 a year that we're training. And then our fellows, it depends on the year. So we have 7 funded positions. This year, we only have 3 of those filled. Last year, we had 6. So it's just a matter of being able to recruit people into this amazing field. Not enough people are going into geriatrics. I wish more would.
So are we actually producing enough geriatricians to meet the demand for them?
No, I don't think we ever will. But I think there are 2 issues. One is that one is we need to we need to produce as many geriatricians as we possibly can. So we're doing our best, to try and recruit and fill our fellowship the best we can. And so are the programs around the country. The second issue is making sure that there are enough geriatrics jobs for these people. So there are times when there are lots of geriatrician jobs out there and people are looking and looking and can't find any. And then there are times when the healthcare systems are sort of facing some financial challenges, which is happening right now, where there aren't any jobs. So for example, from last year's fellows, 2 of the fellows who really, really wanted to stay in Hawaii and were wonderful geriatricians both left the state because they couldn't get jobs here in Hawaii that they wanted. So I think it's a little bit of both. We do need to recruit into the field, but then we also need to make sure these jobs are created. There's a lot of talk about neighbor islands. There's a huge shortage on neighbor islands. Kauai has 4 geriatricians. Maui has 0. The Big Island has, I think, 1, and no, sorry, 2, but 1 is not really practicing in geriatrics. And then one of our graduates is going to go there this fall. So then they'll end up with 1 more. But again, the guy who's going to Hilo, he was worried. He has family in Hilo. He and his wife really wanted to go back there, but he was kind of giving up. Finally, he did get a good job there. But, we need to provide these jobs too for geriatricians on Oahu and in the neighbor islands.
Understood. Thank you. Thank you so much. If there are not any more questions, I'd like to thank on behalf of all the participants. Thank you,
Sorry,
Dr.
I see one other hand raised. Audrey has
Oh,
raised.
I see Audrey's hand up. Go ahead, Audrey.
Yes. Hi, Dr. Masaki. I'm always a big fan of yours. Questions as it relates to the private physicians. You're mentioning that they can't find jobs. Are you saying that these geriatricians are only have jobs in health systems, or are any of them opening up private practices? Because I get requests all the time from families who are seeking a geriatric consult, and
Yes.
especially when their primary physicians are retiring and they know that mom and dad really need a geriatrician. So besides from a handful that I know of, I don't know who to send them to.
Yeah, I think that's a huge problem. Part of the issue is if you open up a private practice in geriatrics, you're not going to make it financially.
That's great.
Basically, that's why most geriatricians go into employment, because what geriatrics does is it saves the system money, but it doesn't make money. It saves money on the back end. So the health systems, I know they see it, they are investing in geriatricians, but not enough. So I'm hoping that that continues to increase. To make it in private practice in geriatrics is extremely difficult. In fact, the people who are doing it, they have to mix it up with younger people, because if you're only going to see people over the age of 65, that means you're 100% dependent on Medicare. You're going to be losing a lot of money.
So Dr.
That's just
Masaki,
how the
Thank you.
Medicare system is set up, unfortunately.
if I get a call from a family requesting for a geriatric, who do I send them to? Do I go to Queens if they're not Kaiser?
Yeah.
Where do I send them?
So both Queens and HPH have geriatricians. The wait lists are incredibly long. So, so they have to be referred by their PCP. They can't just go to a geriatrician. They have to be referred. And in general, the geriatricians are seeing them as consultants. So they're not going to take over primary care. So the primary care can keep them, but then the geriatrician can see them, multiple times as needed. But the wait list is often 6 months long. So I'm really sad about that. And that's why I feel like I wish people would hire more, because the need is so great. But again, the health systems right now are in trouble too. So I understand, they're looking into savings mode and not expansion. And I hope that my dream is that someday there'll be enough geriatricians so that people will not be having to wait for 6 months for a geriatric consult.
Thank you.
Thanks for that question. I see Representative Shimizu with his hand up. Go ahead, Representative,
Thank you,
followed by Dr. Lewin.
thank you, Dr.
Go ahead.
Masaki, for all the good information. I guess my question was the need for geriatric uh, physicians, the acute need for them, especially on the neighbor island, and then the people having to leave because they couldn't get hired or they couldn't get a good job. And I think you touched upon some of the discussion with Audrey just previously. So is there something that we need to do as far as the system or the arrangements to make it more attractive and profitable for hospitals or medical organizations to hire these people that are obviously needed?
Yeah. I mean, I'm all for looking at this creatively, because I think everybody, including all the hospital leadership, would agree that the need is great. It's just that, I'll give you an example. So if you hire a gastroenterologist or a cardiologist, and, they're doing procedures, right? They're doing colonoscopies and they're doing cardiac catheterizations. They can bill a lot, so they can kind of prove their worth very easily because they're billing for X gazillion dollars of procedures. With geriatrics, it's really subtle. What we're getting from Medicare is really low. But what we're doing is the care we're giving is actually preventing a lot of problems. So we're preventing ER visits, we're preventing hospitalizations, we're providing end of life care. We're actually talking to patients about what do you want at the end of your life. And you don't want to be on a ventilator. Okay, we will not put you on a ventilator. We will not put you in the ICU. So we're saving the system money. We're actually improving quality of patient care and the patient experience.
Mm.
But because it doesn't make money, it's a little bit harder to convince people.
Yeah, it's almost as you discussed that uh they're taking away profits or future profits because like you said, they're saving money, but
Yes.
it's actually taking away their income stream for future, which is a, unfortunate way of looking at things.
Yes. Yes. Dr. Lewin, you have a question or comment?
Yes, thank you. So would I be correct in saying that we have enough fellows positions right now for the needs that we have? Um, and you don't think that we'd benefit from having more slots, more training slots?
The reason I say no is because I don't think we can fill them.
Okay, yeah,
That's the reason. I mean, if we fill them, I actually think to have more slots would be a good thing. But
sure.
we're struggling even to fill the 7 that we have. So I would say no. Right now, we're not looking for more slots in geriatrics.
Okay.
Yeah.
Well, I thank you for that. I just want to say for the others on the phone, particularly legislators, that one of the issues about workforce that I think we need to address together is for those specialties that we really do need more: family practice, pediatrics, internal medicine, and so forth. I mean, the where we could expand our capacity and we could use that capacity here. That's a great way to retain
Yeah.
graduates from JABSOM. And
Yeah.
we also should be adding residencies in emergency medicine, endocrinology, which would be great, helpful, by the way, for geriatrics as well. But anesthesiology, neurology, at least those, we should be starting those and building them here, investing in them, because it's going to keep students here. So the more of those that we can support, the graduates in our community, and they're all those are definitely among those that would work. We need to be doing that as a state. So
Dr. Lewin, just to let you know, neurology will be starting here in the next couple of years,
yes,
and well, oncology.
yes,
And
which is
we've been
good.
talking to them a lot because there are many commonalities, and we're talking about
Yes,
how we can do some common training
very
between
important. Yes,
neurology, geriatrics, and oncology.
yeah. And just by the way, Pedro Aguilar
Oh,
is
yes.
is one of your graduates. He developed the Kupuna Aloha, which is probably going to get a new name, but it's a program to bring more volunteers into caring for Medicare Kupuna who do not have access to home care because it's not covered unless they're eligible for Judy Moore Peterson's program and they're Medicaid eligible. Most of our Kupuna are not, and so they
Right.
have no access to home care. And Audrey and her folks and Caroline Cotterill and those folks are trying to reach out to some of those places, but we basically really, we there's a lot more we can be doing. And anyhow, thank you for all your work and leadership. And Pedro is a great guy. He went back to Guatemala, everybody,
Yeah.
and
Yeah.
he's going to take some of the lessons we learned with that program, which we will be presenting. Hopefully, the Rural Health Transformation Fund will fund that this year.
We've had many of our fellows go back to their home countries and actually start geriatric programs. We've
Yes,
got
that's what he's doing.
offshoots in Korea, Thailand, many in Japan. So that's been really wonderful. And of course, we share all our curriculum. We're super happy. Somebody asked me about this. I wanted to find this out. We had a visitor from Australia a couple of years ago, a geriatrician from Australia. And I remember we were talking about the healthcare system there. She was telling me the geriatricians and the cardiologists get paid the same in Australia. So they have no trouble recruiting to the field of geriatrics. She said the bonus structure is that the cardiologists make a little bit more, but the base salary is the same.
Yeah.
And I laughed when I heard that, and I said, well, ours is very, very much not so.
Right.
Representative Shimizu, did you have a follow-up question?
Yeah, I guess so disappointed that our system is so capital driven that we can't look past that, and with the collective experience and brain power on this screen. I'd like to invite all of us to come up with a way to change that formula so that we can make decisions to hire based on the need and not on profit.
One of the things that actually came out of the mini medical school, this couple that were part of the mini medical school, when they heard about this need, they talked to me, and they've actually donated money to our fund in the UH fund. We created a brand new fund so we can give scholarships to fellows during fellowship, because basically many of these people, they graduate medical school with tons of student debt. And then they're doing 3 years of residency, and the debt is, they're not paying off their debt, so it's accumulating. And then they're being pushed to go into jobs to start paying off their student loans. Well, these folks have donated money so we can actually provide local applicants with a little scholarship, either for loan repayment or just a scholarship if they don't have loans. And if they sign on to stay in Hawaii for at least 2 years of practice after. So that's helped my recruitment so much, because we have some people who really love geriatrics, wanted to do that, but say, I've already got kids. I just cannot live on a fellow's salary, cannot do a trainee salary for 1 more year. So this stipend at least helps them get over that a little. It's not a lot, but it's enough that it helps them make that decision. I'm going to invest in 1 more year of training so that I can get this expertise and hopefully stay in the field for the rest of my life.
Yeah, that's great to hear. We need more of that.
We do. I'm super grateful to this couple for being so far thinking about it.
Okay, well, thank you once again, Dr. Masaki, on behalf of all of us. There being no other questions, let's move on. And next on the
Thank you all
agenda,
so
I
much.
have, thank you. I have announcements. Our next meeting, Kupuna Caucus, will be a month from today, October 3rd. Future Kupuna Caucus meeting topics, you're certainly welcome to continue to send in your suggestions to Senator Moriwaki as well as Representative Chun or myself for future discussion topics. Let's see. Also, before we adjourn, anyone else have any announcements they wish to make?
Hi, Representative.
Audrey, go ahead.
Hi, I just put something in the chat. I just wanted to make a couple announcements from AARP. There's 2 upcoming workshop and conferences, one on Maui and one here in Honolulu. One is featuring Dr. Dukhan. It's going to be the day after the HPTS conference. And he's going to be doing a workshop on brain health and financial decision making. And so in the chat, you can see where you can sign up for that. There's still room. And then also in Maui, there's going to be an Aging in Place conference also on September 13th. So both of these events are on September 13th, when this was in Maui. And so for those who are on that island, please attend this workshop. And finally, AARP is accepting nominees for their outstanding contributions as volunteers for the community. And it's for the prestigious Andrews Award. And you do not have to be an AARP member or be involved in an AARP project, but we would love to have nominations, and the deadline for the nominations is on October 1st. So that's it. I just want to announce it to the group. Thank you.
Thank you, Audrey. So before we sign off, wish everyone who are grandparents a happy National Grandparents' Day on Sunday, and everyone stay safe. I know Hurricane Kiko is supposed to be on its way sometime next week, so everyone stay safe. Thank you so much. Until next time, aloha.
Thank you. Thanks, Rep. Takayama.